A warm welcome to all of you from CAHO to this very wonderful session that we are going to be having on FMEA. We welcome Dr. Robyyn and Mr. Gaurav Loria, who are going to be leading this session. Thank you, dear participants, and welcome all of you to this international webinar series. We have more than 500 plus registrations from over 20 countries. And to top it all, we have our hospitals, the Centers for Quality Promotion, that are joining us today for their monthly quality meeting to join us for this international webinar series. We really appreciate all the hospitals that are connecting today. This is the CAHO Monthly Quality Meeting Initiative. So the first Tuesday of the month for the CAHO ISQua International Webinar Series, we have the hospitals, our members, our Centers for Quality Promotion joining us, listening to us, and trying to promote the concept of quality and patient safety. So what is the aim of this exercise? Which is to promote concepts of patient safety and quality to small and medium hospitals. We have more than 60,000 hospitals in this country. So we want to spread this beautiful message of quality and patient safety. Happens the first Tuesday of every month. And what we typically ask our member hospitals to do is to share a cup of coffee with the fellow hospitals, also with their own members, encourage them to participate and be part of this beautiful journey. So today we have many hospitals that are joining us. Would certainly appreciate all of them. And these are some of the the hospitals that are joining: Vijaya Medical Center, Chennai; Mehta Hospital, Chennai; Nazareth Hospital from Shillong; Fortis Hospital, Punjab, Mohali; Rajagiri Hospitals from Kerala; Nirmal Sai Hospital, Chennai; Caritas Hospital, Kottayam; Meenakshi Hospital, Tanjavur; Bombay Hospital, Mumbai; AJ Hospital, Mangalore; Sri Ranga Hospital, Chengalpat; Fortis Hospital, Vadapalani; Ganga Hospital, Coimbatore; Jabalpur Hospital; Christian Medical College, Ludhiana; PES Institute of Medical Sciences, Kupam. I'm sure there are many more who are missed out and who are joining us today. And these are some of the flyers and collaterals that they have been sharing to invite partners to join this journey. Thank you very much for that. So without taking much time, let me hand over the stage now to Mr. Gaurav Loria. Gaurav Loria is going to be moderating this session for us today. Gaurav, thank you very much for taking your time to be the moderator for this session on application of FMEA to healthcare risk manager. Gaurav is a very well-known person in Indian healthcare. He heads one of the very largest hospitals in India, the chain of hospitals, the Apollo Hospitals. He's the Chief Quality Officer and Head Operations Senior Vice President of Apollo Hospitals. Over to you, Gaurav, to take on the session, to introduce the speaker and to moderate the session. Over to you, Gaurav.
Sure. Thank you. A very good evening to you all. Thank you, Dr. Lalu. Thank you, Dr. Vijay, and the complete CAHO team for having me here today. I think it's a great privilege to be a part of CAHO, plus also, be introducing one of the great speakers that we are going to listen today. I think this is the 28th session of the series. So congratulations on, all the work, because I think these kind of opportunities are very important for all of us to keep learning and keep learning more and more while, a lot of times we get busy in our day-to-day jobs. Dr. Robyyn Clay Williams, she's an associate professor at Macquarie, Australian Institute of Health and Innovation, Macquarie University. She's been working in the field of human factors and resilience in healthcare. And I think this is something which is really very interesting, because this is something which we kind of miss a lot of times, and we don't, it is somewhere in the background, but, we just don't pay enough attention to it. She has been an expert in creating health systems that can function effectively in the presence of complexity and processes that are actually safe, usable, reliable, and ready for implementation. Over a career of more than 40 years in aviation and healthcare. And I kind of personally loved it when I read your profile, Dr. Williams, because the whole match between aviation and healthcare, because a lot of times we draw out similarities between these two industries. As what can we learn from aviation? Actually, Dr. Robyyn has worked extensively to develop and evaluate systems then that take into account and minimize the risk while retaining efficient and effective performance. She has almost more than 125 peer-reviewed academic papers, books, and book chapters. She's also a TEDx speaker, and her 2019 TEDx talk on human factors, which is definitely an interesting one, is available on the global TED.com platform. She's also been a ISQua fellow since 2018. Dr. Robyyn is going to talk on application of FMEA to healthcare risk management. Now, again, failure mode effect analysis is just not a tool that we use because JCI standards ask us to do it or NABH standards ask us to do it. But I think as a tool, it is a very important and a useful tool that helps us to identify the risk factors in any process, any system that we may have implemented or that we may be implementing in our organizations. So from that perspective, I think she's going to take us through on how can we actually implement this tool as a practical application, standards and examples in a healthcare scenario. So without taking more time, I'm sure that all of you are waiting to listen to her and not me. So I would love to hand it over to you, Dr. Robyyn, to please take it forward. Thank you.
Thank you very much for that wonderful introduction. I'm delighted to talk to you today about failure modes and effects analysis and how we use it in healthcare. So failure modes effects analysis, many of you use it already. So what is it? Well, it's a method for ranking and managing risk. And what do I mean by that? We all have to deal with risk within our health system, but we just have so many risks. In a complex system, there are problems cropping up all the time. Deciding, what am I going to deal with? What's the priority here? We need some tools to help us. And this is one of the things that failure mode and effects analysis can do for you. It can help you compare risks of different processes or different things that you're going to put in place and decide which ones are you actually going to address. Particularly nowadays when we're all very limited in the resources we've got, we need to be able to have some advice on choosing what to address. So it enables us to identify the risk, to then analyze that risk and then control that risk. And it can be put together in either a quantitative or qualitative way. So what do I mean by that? So if you were doing a quantitative type FMEA, you would need to have lots of data on the process that you're looking at. So traditionally, a quantitative type FMEA would be done on a mechanical system or a machine or some sort of process where you've got very good data, on how often this thing fails, on the types of failures you get. For a machine, you might have something like mean time between failure data. So you can then do a quantitative analysis. In terms of looking at the severity of things that go wrong, if you were going to do a quantitative analysis, you would have data on, how many people might, for example, die if this process goes wrong, or how many people might get injured, or what is the economic consequences of this? And you might have an amount, like an amount that you would suffer if this particular thing happened. But what we find in healthcare is we often don't have that information. A lot of the processes that go wrong are processes around people, not around equipment or around machines. And a lot of the things that happen, we don't really have a way of quantifying them other than saying, that's a bad thing, but we don't often have, numbers that we can put around it. So we tend to use it in a more qualitative way. So I'll talk about that as we go through, but if you do happen to have a process where you do have very good data on that process, you can actually use a quantitative method. So what do we mean by failure modes and effects analysis? Well, failure mode is really just what can go wrong. What things can go wrong in this particular process, or with this particular system, or with this particular machine, or whatever. And why would those failures happen? What actually causes those failures to happen? And then the effects analysis is what would be the consequences of that failure. And we combine all three of those together, and we can then decide what priorities we're going to assign when we start trying to solve the problem. So when might you use it? Well, I'll talk about this more as I go on, but it's quite a resource intensive process. So you tend to just use it for the big things. So you might be using it to analyze failures, particularly if there's a very high impact of that particular failure, or perhaps something that happens very frequently. You might use it for a process improvement if you're introducing or amending a workplace practice and you really don't know how it's going to fit in with the current workplace and what could possibly go wrong. You might use it ahead of time to analyze and have a look at, well, what are the potential failures that we could see? And you might use it for something like workplace design. So if you're moving your workplace to a new location, so we had a look at this when we moved an emergency department. We built a new emergency department and we had to move the whole emergency department across. You might use it if you're buying new equipment, particularly equipment that you haven't used before or that hasn't been introduced into your hospital or health system before. And you might use it for a workplace redesign involving staffing changes. And that particular is, big staffing changes where there's change of practice of some of your staffing groups. So it's based on the basic risk management model, which is where you look at the probability of something and the impact, and then assign a criticality factor based on that. So a basic risk management model looks like this, where you might assign a low, medium, or high probability of a particular thing going wrong or of a particular event happening. And then you might have a minus, moderate, or significant impact as a result of that event happening. And then we put them in a grid like this, and it will give you some indication of what you should do about it. So for example, in the top right, in the red color, we've got a high probability of something happening, and it's going to have a very significant impact. So that means that you really do need to do some extensive management to actually try and prevent that from happening or to mitigate the consequences of that happening. Right down to the other end, when you've got something that's only low probability and it really has a very minor impact, you might just accept the risk of that and really not do anything about it. So, and for many of the risks that we need to manage in healthcare, this type of basic risk management model is perfectly sufficient. It can be done really quickly. You can do it with individuals or with a very small team, and it really gives you quite a good idea of, what should we prioritize here and what should we address. So, I would highly recommend starting with something like a basic risk management model and really only moving on to things like FMEA when that risk management model doesn't meet your needs. So where did it come from? So it started back in the late 1940s after the Second World War, when everything became a much more technical, and the US military started to use it to just try and predict, mean time between failure of their equipment, so that they could organize things like repair schedules and things like that. In the 1960s, NASA adopted it as part of the space program to try and risk manage the space program. And then it gradually migrated across to all of those high reliability industries that you're all familiar with. So aviation, oil and gas, the automotive industry, and the food industry. And really by the 2000s, it's all over the place. They're using it in all sorts of different industries. It's been used in healthcare since the early 2000s as well. But as we'll talk about today, there do need to be some modifications for healthcare because it has a greater degree of complexity and unpredictability in relation to some of those other high reliability industries. And it's got a lot more people involved. So trying to work out the actual probabilities of things or the severities of things is much more difficult than if you had machinery. So I highly recommend, if you're not already using them, having a look at one of these two tools to guide you with your FMEA. The one on the left is from the Veterans Affairs organisation in the United States. Actually, they're both from the United States. The one on the right is from the Institute of Healthcare Improvement. I would recommend using the one on the right, so the IHI tool. It's much easier to use, it's much less requirement for resources, and it's much quicker. However, if you have lots of resources, you've got lots of time, and you really want to get down there and get some really accurate sort of estimates of things, then I would recommend the Veterans Affairs tool. The Veterans Affairs tool employs additional components to the FMEA, so it has a hazard analysis, for example, that forms part of it. But for most healthcare applications, the IHI tool is easier to use, it's quicker, it doesn't need as many resources. So what I'm going to talk to you about today is I'm going to go through the FMEA from a healthcare viewpoint, and I'm actually mishmashing a few of the tools. So I'm not going to take you through one tool or the other, and you may very well have your own tools that you use. So the tool itself is not as important as the concepts and that you follow the concepts. So generally, most FMEAs follow these steps. So the first step is where you define the topic and decide what it is I'm going to assess. The second step is where you assemble the team together to actually do that assessment. The third step is where you describe the process. And they say graphically describe the process, but you don't have to do it graphically. And we'll talk about that as we go through as well. Step 4 is when you get into the bones of the thing, where you start conducting the analysis. And then step 5 is the final and probably most important step, where you actually identify the actions and the outcome measures as a result of what you found. So just starting with step 1, defining the topic. In order to do a FMEA, you have to be able to define your system, process, or problem. So you need to understand it well enough to know, what are the steps that make up this process? Otherwise, you're not going to get a very good result. You also don't want a process that's too overly complex or has too many sub-processes, because the thing can just turn into this huge exercise and you won't get much more out of it than if you just followed a fairly simple process. So if you have a very large or complex process, it's best to pick the most critical sub-process. And you probably have other tools you use, and I will talk to you about one of them a little bit later in the presentation. But there are ways of actually picking within a broad process, what are the more complex or perhaps more variable bits that you might want to look at, and they would be the ones to pick to do your FMEA on. So, for example, if you were looking at a medication management system, you might just look at one part of it. So you might look at the medication ordering part, you might look at the dispensing part, or you might look at administration processes. And to help you guide that decision, you might look at your incident analysis, for example, like where are we finding most of the problems in this particular process? Are they at the start in the ordering, or are they at the end in the administration, or are they somewhere in between? And by doing that, you can choose what topic you're going to look at. Now, often people do a FMEA to compare topics. So you might find that you're looking at 2 different ways of accomplishing the same task, and you want to have a look at the risk assigned with each to see what's the easiest one that you can manage the risk associated with that process. So in which case you might have multiple topics. You might have 2 topics or 3 topics or even 4 topics. Bear in mind, each time you add another topic, it becomes much, much larger. So the second step in it is to assemble your team. So you really need to have a safety or quality person or risk management expert lead the process. It looks like something that a clinical team could do, but in reality, you really need someone with that safety and quality expertise and background to be able to lead and facilitate it, and also to help interpret some of the things that you're finding. It needs to be a very multidisciplinary team. Part of this process is that you're going to be identifying all the different ways that a process can go wrong. So in order to do that, you need to have people from all the different areas that know something about that particular process. So ideally, you want subject matter experts in all the different aspects of whatever the process is that you're looking at. And you need to include everybody who's involved. If you don't include everyone who's involved, you may miss some of the steps, and it might be a vital step that could be the one that actually fails and causes your process to fail. So it's very important to include everyone involved, and that can be quite a few people. Sometimes these FMEA teams can be 15 or 20 people or more when the initial team's assembled. Now, you really only need all of that variety of people for the describing the process. Once you've actually got your process defined and described, sometimes you can then reduce back to core members that become part of the analysis and outcomes group. And by doing that, you can sometimes reduce to 5 or 6 people. So, but initially, when you're trying to look at the steps, depending on how complex your process is, you might need quite a large team. You can actually meet with different members of the team at different times. You don't have to have them all together at the same time. So if you're dividing your process up, you might talk to a particular team about one aspect of the process and another team about another aspect. But you will need to talk to everyone in the whole process that knows something about how that process is performed. So once you've done that, you can then start to look at describing the process. And the idea is to break the process or problem down into specific steps and number each step. Now, they say graphically describe it. Now, the reason that they say graphically is you don't actually need to do it graphically, because really what you want in the end is a list of steps that are involved in that process. And you could do it by just making a list. The thing about doing graphically is it's much easier to see whether you've missed something or not, because by using things like flowcharts or fishbone diagrams or some of the other tools that you use when you're mapping a process, you can see if there's a step being missed, so you can follow the process through from beginning to end and just check that you've got all the steps that you need. So it doesn't really matter what process you use to do it. I would recommend using whichever graphical type process that you commonly use in your quality management team. So you really want something that people are familiar with. So one of the ones that I use is functional resonance analysis method, or FRAM. I won't talk to you about FRAM, about how it works today, because that's a whole other presentation. So if you're not familiar with it, it's essentially a process mapping tool, and it allows you to map processes that have a lot of variability and to identify where in that process the variability occurs. So let me give you an example, and this one's taking a blood sample. And if you want to have a look in the Veterans Affairs tool, they have an example of this, taking the blood. And they've done it with just a list. So they've got a flowchart and a list. So you can see another way of doing this to the way I'm going to show you right now. But if we just look at the pre-analytical part of taking blood, so this is the sort of thing that we often see in hospitals. So someone turns up in an emergency department, they need to take their blood to try and diagnose what the problem is. And the pre-analytical bit is the bit from when the clinician, whether it's a doctor or a nurse or a phlebotomist, takes the blood up until that blood is registered in the laboratory. So if you're going to describe the process very simply, you would say that, you know, the doctor or nurse would write the referral, they would take the blood and they would send the blood to the pathology. But if you're going to do a FMEA on it, that's not going to give you all the steps. You're going to be missing a lot of steps. So this is an example of what we did when we actually got the experts on board, and we actually did it through observation. So normally you would get experts to come in and tell you about how they do the process. Because we're a research group, we actually went and watched. So we spent a couple of 100 hours in emergency departments looking at different emergency department processes, and one of them was this taking blood. So this is what the FRAM looks like, or our process map looks like in taking blood. And that WAD stands for work is done. So when you're doing these mapping of your processes in your workplace, you need to map the process as it's actually done, not how the guideline says you're supposed to do it, because you want to have a look at what the risks are associated with the actual process, as opposed to the risk associated with you know, how you've written the guideline. Because we often find that, you know, there's a lot of workarounds and the actual process looks quite different to the way the guideline's written. So when we map this out, the green hexagons are those 3 steps I showed you in the previous slide. But when we had a look at the variability and the risk associated with this, we found that these particular 3 activities or sub-steps within the process were the ones that had the greatest variability and therefore were associated with greater risk. So that was the point where they obtained the blood kit, the point where they inserted the cannula, and the point where they sent the blood to the pathology. So if you just use that very simple linear diagram, you would have missed 2 of those key steps that are likely to cause you problems as far as risk is concerned. So that's one of the advantages of actually mapping it out, as opposed to just sitting down and making a list. So once you've done that, as I said, you need to map the processes as it's routinely done. This is really important to remember if you're mapping out an incident, because often when we're looking at something that's gone wrong, we have a tendency to map what went wrong. What we want to do for FMEA is we want to actually map the way the process is normally done rather than the way the process went wrong. We talk about how it goes wrong in the next step, but in this step, we're talking about if it goes well, how it's meant to go. So, and at the end of the step, what you're going to do is you're going to have a big long list of numbered processes that comprise that particular process. Now, they don't have to be in any order. People generally put them in the order in which they're done, but honestly, they don't have to be. You just need a list of all the processes involved, and you need to make sure that you haven't missed any. So, and it will look something like this. You usually put it into a table or a similar thing where you've got a list of all the different steps. So in my little table there, I've only got steps 1 and 2 because I wanted to show you the next bit. So once you've got your full list of all the steps in the process, then we have to go and look at the actual failure mode. So, so you work your way down that numbered list of steps and you think about what are all the failure modes associated with that step. So, what could possibly go wrong with that step, and include everything, whether it's minor or rare. You don't need to just pick the most important stuff, just put everything down that could go wrong with each of those steps. And for each one listed, you then need to think about all the possible causes associated with that. So if you've got a process, so for example, the process we talked about taking the blood, inserting the cannula, the different failures that could happen there, for example, is they could be failures to do with the equipment, or they could be failures to do with the actual person. So we found with inserting a cannula that you could have failures if, for example, it was a small child, and sometimes it's very difficult to get a cannula in, or if it was an older person and it was very difficult to find a vein. Or, we saw one example where the person was an intravenous drug user, and it took 30 minutes and they had to go and get an ultrasound in order to be able to find a vein and insert the cannula. So you list all those potential areas where things could go wrong. And then for each one, you list the possible causes. And I've just talked about some of the causes associated with the cannula failing. And then once you've done that, you want to get onto the effect bit. Actually, just going back to the causes, you can actually use an incident analysis method that your team's familiar with to help you determine your causes. So a lot of people use root cause analysis or fishbone diagrams. You can use Aximap if that's something that you use, or fault trees. So you can either brainstorm the causes, or you can use a formal mapping method like root cause analysis to determine some of the causes. And then for every single one of those failure modes, you will have a cause, and then you also need to decide what the effect is. So what are the consequences that would be associated with this particular failure? So once you've done all that, your really large team that's got all your experts in all the different aspects of the process, you won't need them so much because you then are able to actually do the analysis. So the analysis itself is three parts to it, where you're looking at the likelihood that the thing's going to happen, you're looking at the likelihood of being able to detect it, and the severity. So the first part's having a look at the likelihood of occurrence. So how likely is it that this failure mode is going to occur? So I talked earlier about, for some things you'll have data. So if it's a machine, you'll have a mean time between failure. So you will know on average, how long or how likely this machine is to fail. But most of your problems are going to be around people and around behaviors. And you're really not going to be able to put your finger on exactly how often the failure is going to occur. So the way this works in practice is you use your assembled experts to come up with an estimate. So at the moment, in this particular one I've got here, people use a 1 to 10, where 1 means it's very unlikely to occur and 10 means it will definitely occur. And you estimate somewhere between 1 and 10. Now, some of the methods use between 1 and 5. So the Veterans Affairs method uses between 1 and 5, for example. The difficulty between, there's good and bad things about between 1 and 5. So if you're only using a 5-point score, it's much easier to divide it up, because you can have, definitely happening, very likely, likely, not very likely, not going to happen. So very, very easy to have categories. Whereas if you've got 10 points, you're going to be like extremely likely, almost extremely likely, maybe not quite as extremely likely, but a little bit less. So you're going to have lots of little steps in your 10, but it makes it much easier to get consensus and to be able to rank things if you've got 10. So if you've only got 5 points in there, you know, everyone says, okay, well, you know, it's pretty likely. Okay, that's the answer. But if you've got 6 or 7 or 10 or 20 processes and you're trying to compare to see like which one do I need to look after, like which is the most risky process here, it's much easier to discriminate between them if you've got a 1 to 10 scale. So we usually use a 1 to 10 scale, and you don't necessarily need to get the number right. So it doesn't matter whether you decide as a group that it's going to be an 8 or you decide as a group it's going to be a 7. It's really relative. So when you're looking at all the different processes, you want to know, is it fairly risky or not very risky at all? Oh, sorry, probability. And what's the probability in relation to some of the other processes that we're assessing? So it's more important to get the relationship right than it is to get the actual number right. And also what you'll find is because you have to get consensus. So if you've got 6 people in the room, they're going to have 6 different views on how likely something is. But by having 6 different experts, they'll all have their own perspective. And by talking about it, you get a very good understanding of the risks associated with that particular process. So the actual consensus process is really one of the most valuable aspects of this. So once you've decided the likelihood of occurrence, you then want to look at the likelihood of detection. And one of the problems in healthcare is that a lot of things are not detected at all until too late. They've already failed by the time you've detected it. You know, it's one of the reasons that that it's so difficult to achieve safety in healthcare is because healthcare operates right along that safety boundary. It's very, very efficient to operate close to the safety boundary and not to have a big margin from safety. If you start putting big margins in, it becomes much more costly. So healthcare organisations like to operate right along that safety boundary, but it's very hard to tell until something's gone wrong how close you are to that boundary. So this issue of likelihood of detection, there are many, many problems that you'll find in healthcare that just have a very, very low likelihood of detection. So you need to rate it. So with 1 meaning it's very likely to be detected and 10 meaning it's very unlikely to be detected. And you'll find that a lot of things in healthcare are up around that 5 to 8 where they're not likely to be detected until after they've failed. So the last thing that you need to estimate in your team is the severity. And this is, you know, how likely is that harm will occur? How bad is the harm? So, and again, a score between 1 and 10, meaning very unlikely harm will occur with a 1, and 10 meaning very likely that severe harm will occur. So in terms of healthcare, we're normally talking about the patient. And if you get a score of 10, it normally means that the patient's died. So death or permanent disability of a patient is normally up around that 8, 9, 10 in terms of the severity. So once you've gone through all of your steps and all of your sub-processes and you've estimated the likelihood of occurrence, the likelihood of detection, and the severity if it does occur, we then calculate a thing called a risk priority number, which is an RPN. And the way we do that is we multiply the 3 numbers together and you'll get a score between 0 and 1,000. So if you're using a range of 1 to 5, then you're going to get a score between 0 and 125. So just bear that in mind if you're looking at other work that other people have done. Some people use that 1 to 5 and some use the 1 to 10. So your range is going to be quite different. So I've got a couple of examples in there of step 1, the first failure that we looked at in that might have had a likelihood of 8, a likelihood of detection of 5 and a severity of 8, which will give you an RPN of 320. And then the second one had the same likelihood of occurrence, but it was much less likely to be detected. So it had a likelihood of detection of 10 and then a severity of 8, and it had an RPN of 640. So just by having a process that is not as easy to detect, it could have the same probability of occurring and the same severity, but it has a much higher RPN. So it becomes something, the higher RPN, the more important it is for you to start to manage that risk. So once you've got them all nutted out, and you've got a big long list, generally what we do is we identify the top 10, and they're the ones that we start looking at for improvement opportunities. So you won't be able to fix everything, but it does give you an idea of, you know, which ones are most severe. And you will find that a few of them will really stand out. And then you'll have others, and if you've got additional resources or additional time, you'll be able to tackle some of the ones with lower RPNs. So now, I talked earlier about sometimes you want to compare processes. So rather than just looking at the risk associated with a particular process, you might want to compare 2 or 3 different processes to see which one, you know, is the most problematic. And if you're going to do that, you can actually obtain an RPN for each process by adding all the RPNs for each failure mode together. So you'll end up with a big long table, and Excel's probably a good place to do this, but you can do it in any sort of spreadsheet. And you just add all the RPNs together and you'll have a huge number, but it will allow you to compare, you know, one process with the number of another process and help you make a decision of which process would you rather go with. So our last step, and this step really, I think most of you are very, very familiar with, because whether you're doing a root cause analysis or whether you're doing another type of risk management process, you're always going to have this step at the end where you need to identify your actions and outcome measures. And it's really just your whole quality improvement cycle. So you need to identify the type of action to take, whether you're able to eliminate future occurrence by removing the failure point completely. It's normally pretty difficult to do that in healthcare, but sometimes you can. Whether you can control it, which is usually what we end up trying to do, by implementing sort of mitigating factors. Sometimes you can put forcing functions in, sometimes you can put processes in that drive the process to a safer type of process. And, you know, certainly for some of the lower RPNs, you would just accept the risk. You know, you're now aware that that risk is there. You acknowledge it, you accept it as a known risk. You know, you may not have resources to deal with that particular risk. The one I want to point out, though, is this one about the detection, because, you know, if you get a high RPN and it also has a low probability of detection, so you're not likely to find it, you probably should consider putting monitoring measures in place to try and reduce that. You can quite easily reduce your RPN just by putting monitoring processes in place. And you would then go back. So you have a look, you implement your action, you measure whether the action's implemented, whether it was effective or not, and if any unintended consequences occur, because we know in a complex system that anytime you change something, you're going to get unintended consequences occur as part of your change as well. And by rights, then you should really go back into your FMEA and just have a look and see, has it changed the RPN? And certainly the monitoring thing will bring the RPN down, and you can see that you have actually reduced the risk. So that's the sort of theoretical bit in a nutshell. So I've talked a little bit about how it works in practice when we do it, but I've just taken 2 examples from the literature of 2 very common things that you'll end up doing these FMEAs on, to just show you the sorts of issues that might arise. So the first one is just a general issue, and that's to do with the time taken. So this is taken from a Dutch study, a study in the Netherlands, published in Ergonomics, and they just looked at comparing FMEAs in a few different places and types of FMEAs, and they looked at, you know, what size the team was, how many meetings they had to have, how many people hours were involved, and then how many failure modes they found and the number of actions that were done. And as you can see, I've boxed it at the bottom to just give you a look at like the average for these things. And, you know, team size is an average of about 7, but we've definitely found that you sometimes need 15 or more, certainly with understanding the process. The number of meetings is on average of 6, and they could go for a couple of hours each. The number of person hours, you're getting up around 70, and that's just on average. If you start comparing processes where you're doing multiple FMEAs, you can multiply that by the number of processes that you're looking at. The number of failure modes detected are quite a lot. So you can see even on average, it's 50 failure modes detected. So it is quite an effective tool for identifying the things that can go wrong with a process. And the number of actions is 16, and that's quite typical. So, you have a large number of failure modes identified, but you just don't have the resources to be able to address all of them. So you just need to address the ones that have those higher RPNs. So the first one I just want to have a look at was, and I'll be quite brief with this because I know, we haven't got a lot of time, but this one's to do with radiation treatment. So processes like radiation treatment are quite a good process to do a FMEA on. They're quite a well-defined process. You can actually, you often have data on some parts of the process, so you can get quite a good feel, for the criticality of that. And this one was published in Radiation Oncology. And when you see the slides, if you want to read the whole paper, you could have a look at that. It's quite a good example. So the main processes they looked at, so they actually looked at 3 different processes. They looked at treatment planning following target delineation, and they looked at treatment delivery to 2 different types of tumours. They looked at liver tumours and they looked at spine lesions. And some of the analysis was carried out in accordance with different processes, but it doesn't really matter how you did that. So the one I wanted to just show you today was the first one, which was the treatment planning following the target delineation. And so this is how they did it. So they used a fishbone diagram, which is what you've got here, to have a look at all the different steps within that treatment planning. And you can see, even something as simple or straightforward as planning a treatment, it's got 28 steps in it. And there's probably sub-steps within those 28 steps. So they would have listed all those out. And then the one that we'll look at is this definition of treatment parameters, number of fractions. So this was one of the sub-steps in the treatment planning, was to define the treatment parameters. So when they looked at that, they looked at a potential failure mode was that typing the wrong number of fractions in. So the person who was defining it made a typing mistake when they were typing it in. They looked at the potential cause of the failure, which would mean that they didn't identify the fractions number correctly in the patient record, or it was the wrong patient's record, or they made a typing mistake. And then the potential effects of the failure is that the person could get the wrong dose of radiation. So, and if you have a look at it, they've got the severity, the occurrence, and the detection, and they got an RPN of 60 out of that. So, so it's a reasonably low RPN, but it just gives you an idea of what this might look for when you're plotting it out. So the second one I wanted to talk about, and again, this is really quite brief, but it's to look at reducing the risk of prescribing errors associated with electronic prescribing systems. And again, this is a very common one to do a FMEA on, and it can be quite fruitful because it's an electronic system. You often have quite a good record of the number of errors, the frequency of errors, and things like that. So you can often get quite good data to support this. And this paper was published in B&J Open, so it's freely available if you wanted to go and have a look at the detail of this particular one. So now in this case, they used the scores of 1 to 5. So the previous one used scores of 1 to 10. These guys used a method similar to the VA method, and they used scores of 1 to 5. So if you have a look at it here, this is just a description of the rating scales, and it gives you an idea of the sorts of things that you might rate in terms of that. So for example, in terms of occurrence, a score of 1 might be that the failure was unlikely to occur, and they've got it happening in 1 of 10,000 episodes. So this is the sort of thing you might do if you've actually got data and you can see, and that way you can quantify it rather than having to just estimate, because when you estimate things, you can be an order of magnitude out, you can be way out. So, and again, in terms of the severity, they've actually defined the severity. So whether, death, for example, is the highest severity or permanent disability. And in the likelihood of detection, because it's an electronic system, they know whether it's detected or not. So they can actually go in and have a look at the actual figures for likelihood of detection. So, and what they found out of this was they found 37 high-risk failures with 71 associated cause and effects. So quite effective at finding some of the failure modes within this electronic prescribing system. What they found was none of the steps in the drug administration process were free of potential failure modes. And this is one of the things that you'll find in healthcare. You know, if you go looking, you're going to find this failure mode. So what they found, though, was that prescription and preparation of the drugs was the most vulnerable of the steps. So they all had RPNs of over 48. And I just want to clarify that's 48 out of 125, not 48 of 1,000, because they just used that 1 to 5 score. But they also found the most critical element in the prescribing of drugs, which was the calculation of the drug doses required, which had an RPN of 60 over 125. So that immediately gave them an idea of what are we going to address here. And the way they did it was they plotted it out on this matrix. So it's very similar to the matrix I showed you for basic risk analysis at the start of the presentation. But what they've done with this one is they've got severity on the vertical axis of 1 to 5. And on the horizontal axis, they've multiplied out the occurrence and detection. So as you can see, they've got a scale of 1 to 25 on that bottom axis or on the x-axis. But what it does is it allows them to plot things out and look visually to see, you know, what is in the high risk area and what needs to be addressed. And you can see the RPNs in the red area were those high ones to do with calculation. And some of the other RPNs that were in the 40s are those amber color, the R1, 2, 3, 4, and 5. So it's a nice graphical way of sort of seeing, you know, where the risk lies. So what they then did was they had a look at it, and you'll find this a lot in your organization as well, is that something like drug prescribing, it has a different risk profile depending on where you're doing it. You know, so different hospital, it will be different department within the same hospital, sometimes different wards within the same department will have a different risk profile. So you have to look at it across the different areas where you want to assess the risk. So context is important. So in this case, they looked at it in the NICU and the PICU, they looked at it in acute care, they looked at it in oncohematology and in general pediatrics. And as you can see from this thing, they've got all the high risk failure modes listed, and some areas did not have a failure mode, others did, but the little black dots is where there were errors found in the unit selected. So they had a different profile of failures depending on the unit. So it's not like a one size fits all. The other thing they found too is when they went into the actions to reduce the occurrence, they had to have specific actions for different departments. So your actions, in a similar way that you do in quality improvement, you need to tailor them to the context, and you may find that you have different actions, even for the same potential error or failure mode. You might have different actions depending on the context of that department. So in this case, their corrective actions, they had each unit independently develop plans for their corrective actions, and each unit just focused on the higher risk failure modes for that unit, but some were common to all 5 units. After corrective action was implemented, they went back and re-looked at their FMEA, and they found that they'd all the RPNs had dropped down so that none of them were greater than 32. So it's a way of going back and making sure that what you've done is actually likely to be effective. So the reduction in the RPNs for the high risk was around 60% at almost all the units, and 23 of the 37 higher failure risk modes were now in the yellow area. So just going back to this, I didn't print up where they look now, but most of them moved down into that medium risk area. And the clinical units conducted, clinical audits were conducted by the team leader 3 and 6 months later, and they confirmed that the clinical changes were still in place. So it shows that in the case of the medication management, that it was a very effective way to not only identify risk, but the whole process was also very effective in managing that risk. So they're just a couple of simple examples, and those papers go into quite a lot of detail. There's a lot of publications out there that if you have a particular problem, you could have a look, even if you just look on Google Scholar, and you'll get some nice advice from other places that have done a similar FMEA to the one you're doing, of the steps they found and how they went about it. So I just want to leave you with something else to consider. Like, we're nearly, time's nearly up, but I just wanted to talk about the patient view of risk, because we really are trying to centre our care much more around the patient now. And the patient view of risk really needs to be taken into consideration when you're looking at risk management. And the FMEA doesn't really account for that patient view of risk in the analysis, but we do need to consider it when we start looking at the corrections or the fixes that we put in place to mitigate that risk. The reason is that the patient view of risk can differ significantly from the actual evidence-based risk. So you might come up with all your risks based on your FMEA and your RPNs, but your patients might have quite a different view of what they consider to be high risk or not high risk. And it can come down to their personal experience, it can come down to their fears, and it can come down to their preferences. So where you've got patients involved, you need to consider the patient's perception of risk as well as the result of your FMEA when you're looking at your risk management strategies, because you might need to put things into place that actually deal with that patient aspect of the risk in addition to the things that are identified in the FMEA. And, you know, sometimes if you've got a process that involves patients, you could get a patient representative or an actual patient or carers involved in your FMEA to actually incorporate it within the FMEA. But often what people do is they just do the FMEA within the quality and safety department and the clinical department, and then they apply the patient perception afterwards to just make sure that's taken into consideration for any quality improvements that you put in place. So just to give you an example of this, there's this hazard versus outrage. So we talk about the risk in terms of probability and severity, but for a patient, it's often this hazard versus outrage. It comes from Peter Sandman's work, but it talks about actual risk versus perception of risk. And if you look at the little diagram on the right, you can see that, you know, the perception of risk of things like a terrorist attack or a plane crash is much, much higher than the actual risk. I mean, in Australia at the moment, we've got this thing with windmills, because we're trying to get away from our coal-fired power to alternative power sources. There's an amazing perception of this risk associated with windmills to people's health. And, you know, when you compare the perception to the actual risk, there's quite a big difference. And people don't just overestimate risk, they also underestimate it. So, you know, things like ongoing things like a traffic accident, people don't think that's, you know, much to worry about, yet the risk of a traffic accident and being injured in one is really quite high. In the same way, people don't think about cancer until they or a family member is diagnosed, whereas the risk of cancer, you know, probably a third of us are going to die from a cancer. So, and the sorts of things that can make that risk, you know, into outrage are the things that I've got on the left. So, you know, where something happens to a patient that's not voluntary, or something they're not familiar with, or something that they dread, or you know, or something that they feel is unfair, or where they don't trust the clinicians. You know, their perception of risk can be much greater. So so that's just a very, I guess, short summary of how we look at FMEA in healthcare. But in summary, it's a very useful tool for analysing particularly high impact failures, particularly critical changes to workplace practice, and particularly large scale workplace redesign, where you've got a large budget and plenty of time to actually do that analysis before you put something in place. It can be very costly, it can take up time, and it can take up a lot of resources, particularly if you're looking at complex processes or you're looking at comparing processes. You often need a large multidisciplinary team who have expert knowledge in the processes you're analysing, and you definitely need a safety and quality professional to lead and direct the process. Most of the risks you will encounter in healthcare, unfortunately, involve people, and they involve behaviours. So don't worry too much if you can't come up with actual numbers for your ratings, where relative ratings are okay. if you can establish that the risk of this is going to be more likely than the risk of that, that's all you need to do. You don't need to know whether it's actually an 8 or it's actually a 6. It's really, how they relate to each other. The ratings will require consensus in your team and allow for that. It can sometimes take a long time to actually get that consensus, and that's where your safety and quality professional comes in there to help facilitate and lead people towards that consensus process. But the process of building that consensus is awesome for teamwork. Like, you can build some really good teamwork, and you can get some really good insight among the team members of other parts of the process that they may not have been familiar with, and how their work can have an influence on that part of the process that they might not have been familiar with before. So it can be quite useful in that sense. So thank you very much for your time today. My contact details are up there, so please feel free to contact me later if you have any further questions or need more information. So I'll just stop sharing, but thank you very much.
Thank you, Dr. Robbins. And I don't think I was mistaken when I said that, you are really an authority, and, you have got so much of experience, and you could explain all these things in such a simpler, well, and a very effective manner. I think this was like a presentation or a concept storytelling, wherein people could who don't know anything about FMEA could have learned it better, and who must have known, okay, what are the things that they would not have been doing in the past, and they could do it. So I could myself actually look through it, and some of the visualizations that you had presented on how can we visualize it, I think that was amazing. So thank you so much for that. And on behalf of the audience, I would like to thank you as well. I think there are too many questions if I look into the Q&A section, and that actually shows the interest that people or you would have been able to create with your presentation. So I'll very quickly just pick up, very few questions. So, one of the questions that I would like to pick up from there is, what's the broader difference, or if there is any specific difference between the way we do FMEA or HFMEA?
No, it's just a term to denote that it's a healthcare. So the HFMEA is really from the Veterans Affairs process, and it's a more complex process that involves a hazard analysis as well. So you can use that, but often there's a compromise between what resources do you have, how much time do you have, and what you get out of the process. So yeah, so no, there is a variety of ways to do the FMEA, whether it's HFMEA or FMEA, as long as you follow those processes where you break whatever you're looking down into steps, and then for each step have a look at what are the likely failures, what are the likely effects of those failures, and then assign the occurrence, the severity, and the detection. It'll work. So there's no right way or wrong way. There's many ways of doing it. It's really a case of choosing something that's within the resources that you have available to do it. It's more important to do a smaller or more abbreviated version within your resources than to not do it at all, because you don't have the resources to do the big VA version of it.
Sure. Thanks. The next question is actually, when we do these scorings of, the probability, the severity, or even the detectability, a lot of it is actually very subjective, because it depends on how we perceive it or how we look at it or what is our understanding.
Yes.
Do you think it would affect the outcomes in some or the other way?
No, so this is part of why you need a diverse team, because if you just have one or two people do it, it is subjective. It's because a lot of the problems in healthcare are around behaviours and around people. Trying to estimate like how often is this behaviour going to occur. I mean, it's why you need a diverse group of people who have different looks at the process, and then decide as a consensus what they think the answer is going to be. And as I said, it doesn't matter. You don't have to get there's no right answer. It's more a relative, like how is this one compared to that one, more than whether you've got an actual right one. So, but yeah, you can't, this is part of it. When it first came across from, like, I used to do these things in aviation where it was all done with a calculator and numbers, you know, you have like 3 by 10 to the -8 and 4.5 by 10 to, and you multiply all that out. And I came across to healthcare and people were trying to estimate, like, you know, how often someone would make a medication error, and they're going, oh yeah, it might be 1 by 10 to the -3 or 1 by 10 to, I mean, no idea. You know, you really just need to be able to estimate, is this something that is super likely? Is it something that's not very likely, or it's never going to happen, or my goodness, it happens every single day? And if you've got the right people in the room who know about that process and how it works in the real world, they'll be able to come to a consensus on that.
Yeah, I think that was a very beautiful way of putting it and answering that. The next question is, so when we are doing this RPN number calculation, and then there are, let's say, 3 or 4 risk steps or risk areas that have almost similar or maybe similar risk priority numbers. How do you go about in prioritizing which ones to look out for, or is there any other way of, sub-prioritizing them, or do you think we should just take up all those 3 or 4 that are, and I'm just modifying the question a bit that was put up in the Q&A section.
Yeah. So, yeah, you really, if they've all got the same number and you've gone through the process, you really need to look at all of them. It's one of the good things about what I was suggesting with the score of 1 to 10 rather than 1 to 5. You'll get more discrimination amongst them. You'll have an idea, like what we find is that you have a group of them that are high, and you have a group that are medium and a group that are low, and you really need to just talk about the high ones. What you'll find is, even with ones that have a very high RPN, you may not have the resources to deal with it. So what you do is you just go through all the ones that are that are high, and have a look and go, well, what can we do? What can we do about this? And I think there's not really an easy way. I mean, it's like anything, if you've got like 5 things that you've got to do, the prioritizing of that then becomes a management type prioritization, because they're all equally risky. So you then have to take all your management aspects into account. So how expensive is it, how long is it going to take, and so on and so forth.
Yeah, I agree. I think the last question that I would like to pick up from here is, are there any specific areas, departments, or processes that you would suggest that where a continuous process or kind of FMEA should be done on a regular basis, or is there something that is it very arbitrary that we just pick up based on what we think would be a unsafe process, or we want to improvise on that? How do you think we should look at this, or what approach should we have?
Yeah, choosing what to do is difficult. It takes a lot of resources, so you just want to pick things that are going to cause you a problem. Like, I wouldn't just be doing it just for the sake of doing it each 6 months or 12 months or something like that. I would do it if something's changed. So if you get one and you put something in place and you get your RPN down, you might want to check it in 6 months and just see, is it still effective? I wouldn't just be doing them just for the sake of it. I think the resources are probably better used on things that are problematic. Have you had a lot of incidents around something, or has there been something gone really wrong here, or is this something new that we've not done before? How are we going to work out, where's the risks associated with this thing, because we haven't done it yet? I'd put the resources there.
Yeah, and I think just to add onto what you said, from my experience, especially when we are moving from a manual to an automation system or vice versa,
yeah.
I think that is one very typical example where we should definitely do kind of a FMEA to figure out what are the risk points and what do we need to watch out for, so that we don't end up any specifically patient-related issues when we work in a healthcare environment. And I think largely anything and everything that is involved or revolves around patient safety could be used as an approach, as an area where, we can pick up FMEAs to do as projects, as processes or tools to improvise?
Yeah, something that just occurred to me when you were talking about, do you do them regularly? You can actually share them. So if you're doing one on a particular process and someone else, in another hospital or in another organization is looking at the same thing, they can start with one you've already done and it can make it a bit quicker. So that's a possibility too. We often find in Australia that people won't share them because they're often done around incidents, like if a patient is disabled or they die or something like that, and then it becomes a privacy issue. So they won't actually share. But if you're doing the sorts of processes that are very common, so like, medication management or something like that, you can actually share them and it will give you a starting point.
Yeah. So thank you once again for that. And I will kind of give it back the session to Dr. Lalu and Preeta and others from the Central CAHO team.
It was a delight. Thank you very much.
Thank you so much. That was excellent indeed, Dr. Robyyn. Great presentation. And as Gaurav mentioned, the feedback, if you go through the chat box, you will notice the kind of feedback that has come. That says it all. Brilliant presentation. So as a mark of our appreciation to the time and the efforts taken by you, I would request Gaurav to hand over a virtual certificate of appreciation to you, Dr. Robyyn. Over to you, Gaurav.
I would have loved to have done this in person, but since we have moved to the complete digital world, so thank you once again, Dr. Robyyn, and thank you. And this is just a small token of appreciation from the CAHO team, from all of us. Thank you.
Thank you very much.
Thank you once again, Robyyn, for the wonderful session, Gaurav, and all our partner hospitals and centers for quality promotion who have joined us today. Thank you. Have a great evening. Bye-bye.